Okay, so the title of my talk is Ankylosing Spondylitis Update, and I think I've got quite a reduced audience. Okay, so I was going to really talk about, for the next half hour, ankylosing spondylitis and our approach to it and what things have changed. Quite a lot of things have changed over the last year in terms of the regulations. So really, rheumatologists' approach to ankylosing spondylitis is to deal with the condition in all its aspects and to try to meet the patient's needs. Obviously, if you're an international cricketer, then your needs are going to be different from people who are not. So ankylosing spondylitis is best seen as a manifestation of a group of conditions. And this group of conditions I've put up there on the slide. You've got psoriatic arthritis, uveitis, reactive arthritis, patients with inflammatory bowel disease. There are juvenile forms, and there's a term that we use when we're not quite sure what's causing things or what subtype it is, called undifferentiated. These pictures on your right-hand side show on top someone with iritis, which is apparent, at least in this picture, with someone with conjunctival injection. There's a red ring around the coloured bit of the eye. And then there's someone with psoriasis, and then there's someone doing foot exercises for plantar fasciitis at the bottom. So, ankylosing spondylitis isn't just a condition of the back. It's a condition that is predominantly known to affect the back, but it can affect the peripheral joints. It can also affect the insertions of tendons and ligaments into bone, called the entheses. And there are also components where it can affect possibly the lung and the heart, and they're called extraarticular features. So I'm just going to talk about the rare extraarticular features quickly, just so that I can ignore them. Some of the extraarticular features I've already mentioned. The anterior uveitis is the inflammation in the eye. It can affect rarely the heart and the lungs. People do get bowel trouble. You can get problems with one's nerves, and either the treatment or the condition can sometimes affect one's kidneys. I think I've got a slide on the pulmonary involvement. Fatigue. Fatigue is a very common symptom that patients with ankylosing spondylitis suffer from. It is actually quite a difficult thing to treat, and is something that a bit like joint pain and back pain is not something you can see when you look at someone. 1/3 of patients report that nothing helps with their fatigue. The strongest association of fatigue is with pain, and there is also an association with depression, which is perhaps not surprising. And then biologic therapies, in terms of anti-TNF agents, are not that great at improving fatigue. Now, this is the slide I promised on lung involvement. It does happen rarely, and people get fibrosis classically at the top of one's lungs. And sometimes in patients who have lung involvement, we'll do scans and try to assess that. I mean, obviously, people with ankylosing spondylitis who have a rigid spine and constricted rib movement as a result do actually get breathless and some restriction in their chest movements without actually necessarily affecting the lung. And then perhaps people who go on for longer periods of time then later get the upper lobe involvement of the lungs. So, the main manifestations of ankylosing spondylitis is axial and peripheral disease. So by axial, I mean pain and inflammation affecting the back, and that's the entirety of the back. And there's a picture on your left-hand side which shows someone who's got an increased kyphosis, or an increased curvature in their back. And people with ankylosing spondylitis develop different postures. The X-ray you can see there in the middle of the picture shows long-term changes due to ankylosing spondylitis in the sacroiliac joints. And the pictures on your right-hand side show inflammation in the fingers, deformity in the fingers, and then there's what we call a sausage toe. I don't know if it looks bright red, the index toe there on the right foot. That's what we call a dactylitis. So ankylosing spondylitis has these manifestations generally of back pain, inflammatory back pain, and also peripheral joint involvement. Now, the management of ankylosing spondylitis really follows a pattern that I've talked often about before, so I'm sorry if you've come across it. I've got those two orange boxes with axial disease and peripheral disease. Just need a little bit of a pointer. There we are. So you've got axial disease and peripheral disease. And the reason why these coloured blocks are there are to show that anti-inflammatories cover both of them, that exercise on this far left-hand side is a mainstay of treatment and also is for both of them. Painkillers cover both of them. Surgery is appropriate for both of them. But some drugs, so for instance sulfasalazine, may be more appropriate for when the ankylosing spondylitis affects your arms and legs and your peripheral joints, rather than affecting your back. And then biologic therapies, or TNF blockers, have been shown to improve both. And I say biologic therapies rather than TNF blockers because there are other biologic therapies that are not TNF blockers that can improve ankylosing spondylitis. Then there's local corticosteroids. Now, we often inject joints to try and help with ankylosing spondylitis, and it edges a little bit underneath axial disease because sometimes we can inject the sacroiliac joints in the back. Now, as I said, education and exercise and physiotherapy and daily exercise in particular, having a routine, is the cornerstone of management of ankylosing spondylitis. It's been shown that supervised exercise is better than unsupervised exercise, and that being part of a club or a patient association such as the National Ankylosing Spondylitis Society is helpful, and patients who take part in these societies can do better. So in terms of the painkillers, we've got paracetamol and we've got opioid-like drugs. So for opioid-like drugs, we mean things like codeine, tramadol, buprenorphine patches, and ultimately morphine. Now, generally speaking, we're not too fond of opioid-like drugs, but sometimes we have to use them. And then in terms of surgery, you have hip replacement for people with hip involvement, and then sometimes for some people with really quite severe back deformities, some people do consider surgeries for them, although patients have to be chosen very, very carefully. So, back into the generality of most people's symptoms with back and peripheral disease, the first line that most people try is anti-inflammatories, okay? Now, there are lots and lots of anti-inflammatories. I think there are at least 11 ways of interfering with the anti-inflammatory pathway. And if the drug name has got a different ending, it tends to interfere in a different way, okay? So if, for instance, you've tried, I don't know, ibuprofen, and it doesn't work for you, maybe something that ends in a different way, like diclofenac, might work better. So if, for instance, you are trying anti-inflammatories and one doesn't work, Don't necessarily give up on all of them. You can try something else. Not all anti-inflammatories suit people. Some are better for some than others. And really, it is just a matter of trial and error. Now, you can't really say that one is better than the other. Some are licensed for use in ankylosing spondylitis and some aren't. And sometimes that affects the ones that we choose. But generally speaking, anti-inflammatories are anti-inflammatories. Some people say that the ones that end in coxib may be safer in some regards in terms of upsetting your bowel. Whether or not they're universally safer in all respects is still out for consideration. Now, some people say, should you use them all the time? Well, there is evidence to suggest that continuous use does prevent some of the bone formation that occurs in the back. But balancing against continuous use is that we know that higher and longer term use can lead to bleeding in the bowel and possibly will increase cardiovascular risks. And so generally speaking, people do tend to suggest one should use the lowest dose that works for the shortest period of time. Now, this is just a graph showing that people with the circles that use the continuous anti-inflammatory treatment compared to those who just take it when they need it, the people that use it continuously have a slower rate of change in their x-rays. And this is just an example of what the changes in the x-rays are and how the scoring system works. Now, after you've tried anti-inflammatories, we move on to disease-modifying drugs, and we largely use sulfasalazine, and to a lesser extent, possibly, we also use methotrexate. There is very little evidence to suggest that they work with ankylosing spondylitis affecting the back. There is some suggestion that maybe sulfasalazine helps a little, but it is only a minor note on a paper. But sulfasalazine does seem to definitely work when ankylosing spondylitis affects one's peripheral joints, so one's hands, feet. And then there are steroids. And generally speaking, we try to avoid giving people oral steroids continuously. Sometimes we'll give intravenous pulses, so that means sticking a needle in your arm and infusing it around your entire body. But generally, if we use steroids, it's with local injection into peripheral joints. This is just an example of someone using an ultrasound machine to inject the sacroiliac joints in the back. There's an ultrasound image on the left, which is like looking at a cloud, but really you're supposed to be able to see this needle here, but unless it's moving, it can be quite hard to see. And this is just an example of people reporting improved back pain and changes on the MRI after steroid injection to the back. So the MRI improves from before the injection to after the injection, and the pain score improves from before the injection to after the injection. That was a relatively small study done over a relatively short period of time, and generally speaking, we don't use repeated steroid injections. So next we move on to biologic treatments. Now, there's a variety of drugs that are targeted towards this molecule called tumor necrosis factor alpha. They are controlled because they are expensive, but they're controlled by NICE. They work by binding to this molecule called TNF in the body, which is a signal molecule involved in inflammation. TNF does lots of things, and so there are all sorts of concerns about what you might be blocking, but to a great extent, we are quite pleased with how TNF therapies tend to be safe. They might increase one's risk of infection a little, but they are generally very well tolerated and quite effective. NICE, back in 2008, allowed it to be used in patients who met stringent New York criteria for ankylosing spondylitis that required X-ray damage. Now, X-rays are things that change relatively slowly, and over the years, people have wanted to be guided primarily by symptoms for inflammatory back pain, and also people didn't want to rely on X-rays. So there have been for almost a decade now, well, just on 7 years odd, there have been criteria for diagnosing what's called axial spondyloarthritis rather than ankylosing spondylitis, still same initials, but there have been changes to the definition so that you can say that you've got axial spondyloarthritis and you don't need X-ray changes. You can have a blood test and some symptoms, or you can have changes on MRI. Now, changes on MRI occur much earlier than the X-ray changes. And this year, after some positive noises last year, in February, the most recent guidelines were published, and this basically granted approval from NICE for biologic agents to be used for ankylosing spondylitis, but also a subset, adalimumab, certolizumab, and etanercept, can be used for non-radiographic axial spondyloarthritis. So that means in the absence of X-ray changes, we can now use some of these TNF blocking drugs. It did specify that inadequate response and intolerance to anti-inflammatories is required, as has been always the case, and it did specify that you should use the cheapest drug. Now, our traditional threshold for treating someone with ankylosing spondylitis with TNF agents are these criteria. So that's a disease activity score of more than 4 and spinal pain of more than 4, and it's got to be repeatedly like this. Now, in the new guidance, TA 383, it doesn't actually mention the threshold. It simply says that if you don't respond to the anti-inflammatories, then you can then go on to these other drugs. Whereas the previous guidelines, which this slide is taken from, specify that you've got to fail at least 2 anti-inflammatories. Whereas my reading of the guideline seems to suggest it's a bit more nebulous. But it does give us slightly more clinical freedom, particularly if you read the precise wording of the guideline. Now, once you've been on biologic therapy, both the old NICE guidelines and the new NICE guidelines specify that treatment at 12 weeks should lead to a 50% reduction in the disease activity score, and it needs to be of at least 2 points or more, and a reduction in spinal pain, okay, by 2 centimeters out of 10 centimeters. So as long as it works, then you can remain on it. Now, in actual fact, some of the data that's been produced seems to suggest that 60% respond. I think in real life, more than 60% respond. This is one of the early figures that were produced. Now, then patients ask me, well, what if I fail my first TNF? Okay, so once again, thanks to the work of actually the National Ankylosing Spondylitis Society and patients and doctors throughout the country, NICE have listened, and they have actually allowed switching. So whereas before, if one biologic therapy didn't suit you, you couldn't change. Now, if a biologic therapy doesn't suit you, you can change. Okay. If you're on golimumab, because golimumab is a higher dose, if you're heavier than 100 kilograms, then the dose is sometimes just increased. Other drugs such as rituximab and abatacept which are not TNF blockers, haven't been shown to be that successful. But newer agents, such as secukinumab, which block IL-17, have been shown to be effective. So secukinumab is subject to this abbreviation, which basically stands for Guideline in Development, Therapeutic, what's it? Something appraisal guidance, 517. So the last one for AS was 383, now this one's 517. And at the moment, we're at the final appraisal determination stage, which means that we're almost there. We're almost there, okay? So NICE has almost granted approval for use of secukinumab, and the criteria in the draft guideline seems to be that it's recommended if you have an inadequate response to anti-inflammatories or anti-TNF. Now again, the wording of this seems to suggest that you don't have to have failed anti-TNF to try secukinumab. And then there's this line which is basically only if the company, presumably the company that makes secukinumab, agree a discount to the NHS. So once they've done their bargaining, hopefully we'll get approval to use secukinumab. And the way in which it's used, it's an injection under the skin, 150 milligrams every week for the first 5 weeks, so 0, 1, 2, 3, and then 4, and then every month. Okay, the way in which it's worded is 1 injection weekly on 0, 1, 2, and 3, and then every month from 4 weeks. So, I'm sure this is probably published by now, but when I did this, I only had it as an abstract. This showed that patients treated with secukinumab were 99.8% likely to be better on the treatment rather than placebo, and there was a 60% improvement at 6 weeks. There were some increases in infections, and that the response was quite quick. And then they moved on to the Measure 2 study, where they recruited a lot more patients, and they found that 74% of patients reached ASAS-20 response criteria at 1 year. Now, they have been giving this treatment to patients with psoriasis, and so we do have safety data in a much bigger population of patients. Now, another drug that may be on the horizon, but maybe not as advanced as secukinumab, is ustekinumab. Now, ustekinumab blocks IL-12 and IL-23. Now, to you and me, these are just numbers, but I am going to be talking about different sorts of biologic treatment after lunch if you want to understand them more. But ustekinumab has been shown to be better than TNF therapy in treatment of psoriasis. Now, if you remember that most things that we use in ankylosing spondylitis have largely been borrowed from rheumatoid arthritis. And now we know that rheumatoid arthritis is really quite different from the seronegative conditions like ankylosing spondylitis and psoriasis. And here we have data coming from psoriasis showing that anti-IL-12/23 ustekinumab works better than the biologic TNF treatments in psoriasis. So maybe it'll work better in ankylosing spondylitis than the TNFs. We don't know. You need a head-to-head trial. Now, as I said, there are trials ongoing on ankylosing spondylitis, but they're nowhere near the, as far as I understand anyway, approval by NICE. So that sort of really is a summary of the treatments for ankylosing spondylitis. Physiotherapy is the mainstay. Anti-inflammatories are used frequently. You can use painkillers and rarely surgery. Some people are suitable for sulfasalazine and corticosteroids, but after you've failed anti-inflammatories, most people will move on to biologic treatments. Now, in summary, we do try and treat people as individuals and try and treat every manifestation of their disease. Ankylosing spondylitis has now sort of been split into its typical ankylosing spondylitis and axial spondyloarthropathies. Thankfully, we can treat all of them in a very similar way. And NICE has now approved that. And very soon, hopefully, we'll have access to IL-17 anti-IL-17 treatments for people with ankylosing spondylitis. So, does anyone have any questions? I know there was one question at the front, but if anyone's got any questions on ankylosing spondylitis and anything I've mentioned, that would be great first.